Ready? Hello, everybody. Good afternoon. Today is an Engel Rounds presentation by Dr. Lee Kehoe from the Department of Psychiatry. And I'd like to do a brief introduction of our speaker today. So Dr. Kehoe is one of the newer faculty members in the psychiatry department, starting in mid-2024. She's a longtime Rochester resident. She received her Bachelor's of Arts in Psychology and Bachelor's of Science degree in Brain and Cognitive Sciences from the University of Rochester. Then obtained a master's degree in clinical mental health counseling from the University of Rochester, and finally received a PhD in clinical mental health counseling from also the University of Rochester. She then went on to complete a postdoctoral fellowship as part of a T32 program in supportive care and cancer in the Department of Surgery. And then after that, transitioned to a faculty member as of July 2024. She currently has a KL2 award through our CTSI and NIH, and also was the recipient of one of the internal pilot grants in psychiatry this year. In addition to this research, she provides clinical services in the Psycho-Oncology clinic at the Wilmot Cancer Center, and has for many years prior to becoming a faculty member here, delivered outpatient psychotherapy in the community. And so she's quite an experienced clinician and now a research faculty member as well. Okay, so without any further ado, please welcome Dr. Lee Kehoe.
Hi, everyone. Thanks for being here. I do hope you got a little sunshine before coming into this room. I'm excited to be here today to talk about, okay. Is that better? Thumbs up? Okay. I'm excited to be here to talk about area that's really close to my heart and has driven a lot of my clinical work and research over the last many years. And that is in dyadic psychosocial interventions, and more specifically there in this talk today, thinking about how we integrate the caregiver more into supportive care in cancer. So as a quick overview of what I'll go through, thinking about why dyadic interventions matter, specifically in psycho-oncology, and touching a little bit here and there on how it is transferable to some of our other work as clinicians in mental health. The burden and characterizing the burden of cancer for patients and caregivers, giving a little bit of an overview of current practices and dyadic interventions in cancer. And then as an example of an adaptation, talking through my recent work in dyadic life review therapy, and then talking through a little bit of future directions and implications we all might want to think about going forward when it comes to dyadic interventions. So I wanted to start with this quote: "To be human is to need others, and this is no flaw or weakness." And Sue Johnson, she's done some work in emotion-focused therapy. And the reason why I like talking about this quote in the context of relationships is because even the introverts among us need people. And if we think about needing people specifically in the context of caregivers in cancer, there's a bit of a paradox there, because the caregiver is putting out so much energy towards another person and really getting little support in return. And then secondly, if we go a little further to think that needing people is a strength, it really gives a lot of opportunity for thinking about how dyads as a unit might be a strength for us as clinicians to kind of foster that unit and help them and support them for what they already are doing together. And to speak a little bit to my work that Steve mentioned, you know, in the community, I worked for a long time in long-term care. And initially, caregivers weren't completely on my radar. I did a lot of work in geriatric mental health and chronic disease, but I found myself working with the caregivers constantly, maybe more than the patients sometimes. And it really kind of demonstrated to me how much they were going through, because to, interface with them at first, they seemed okay and they were really doing it all. And you wouldn't think they were suffering, but as you hear their stories and you get to kind of hear the breakdown of what they're doing day to day, the suffering starts to come through a little more. So those experiences really kind of shaped my research as I came back over to U of R to complete my fellowship. And so to contextualize cancer a little bit and caregiving for you all, we all know that cancer is a major challenge globally and in the US. And in 2024, there were 2 million cases of cancer diagnosed. But with that, our survival rates are improving and the treatments are becoming phenomenal to support people and help them live longer. But the other side of people living longer means there's, side effects from treatment and transitioning into survivorship and all the kind of impact that has on a person's life. And so if we think of the caregiver in relation to that experience and the compounded burden that puts on the caregiver, it kind of helps paint a picture for what cancer and survivorship are creating for caregivers. And so it's a real pervasive problem. And caregivers, like I said earlier, I think within our infrastructure of our healthcare systems, we don't really see and they don't express their distress, and they're really doing it all and keeping it together. And survival mode can be so powerful for people. But when you take an opportunity to hear their story, you start to realize where that suffering is happening. And I'll talk a little more about my intervention to think about that story piece a little bit later. To think about caregiver burden a little bit more in depth, we talk about this idea of mutual reinforcing distress. So mutual reinforcing being when one person's distress starts to increase, the others also increases. So if we think about two people operating together in life, cancer kind of overtakes all of these pie pieces, but outside of cancer, they're still living their life. They're still performing their maybe jobs. They're still, sometimes caregivers are parents to their own children. Sometimes they still have parents still alive, depending on what age they are in life. So they're managing a lot outside of cancer, and now you're adding cancer on top of that and caring for another person altogether. And so there's a lot of invisible layers that we don't really see that people are managing when we're working with them from a mental health perspective. And then thinking about, too, a history between a dyad. So this is kind of an adaptively functioning cycle, but there may be many dyads that already are not functioning adaptively. And so we're adding cancer and navigating that in the mix, and that can kind of lead to a lot of chaos for people and become a bit of a slippery slope when it comes to juggling a lot of these pieces. So the mutually reinforcing distress is kind of a centerfold for thinking about why the dyad is a really great opportunity to focus on when it comes to psychosocial interventions in cancer. And I wanted to touch just briefly on the physical toll of caregiving in cancer. I think the heart of this has to do with mental health and emotional health, but the physical toll is a real issue for caregivers as well. And there are higher rates across a lot of areas, specifically cardiovascular disease, hypertension, sleep, and chronic pain. And all of these also, there are some studies demonstrating that caregivers are at risk for mortality, and the chronic stress is really impacting their immune systems over time. And so thinking about the physical toll of caregiving in the context of cancer also gives a bit of an opportunity. There's a lot of great work being done in support of curing cancer that is kind of multifaceted and brings together exercise, training, diet, nutrition, and mental health as a way to work with the dyad together to kind of target a lot of these outcomes. So I think it gives a chance to think about how we take the interventions we're using and maybe integrate some of these other physical interventions, or also even collaborate. There may be caregivers who are navigating cancer so heavily, they're not navigating their own healthcare. So if we're faced with a caregiver, we have an opportunity to support and perhaps connect them with other providers in the community. If we're thinking too about the psychological toll, which is the main kind of focus in terms of psychosocial interventions, and this idea that cancer is really a shared experience, and that patients and caregivers are suffering kind of together, and cancer is inherently dyadic, I think, in that sense. But to step out of that, distress is also very subjective, and it manifests very differently for any human. So as a clinician working with a dyad, considering that the patient and the caregiver may be experiencing their distress very differently, and what does that look like to inform how we adapt interventions to target that distress for both of the patient and the caregiver. So for example, patients may experience a bit more fear of death because they're the ones experiencing cancer and having to kind of have this existential distress to process what it means to die and have an end date to their life. And with that, a loss of control, perhaps, and not being able to manage a lot of portions of their life any longer because the caregiver is having to do so. And alternatively, some common areas of distress for caregivers are this feeling of being overwhelmed and a bit helpless too, because you're watching a loved one go through something really difficult. And then another common experience that causes distress in caregivers is this idea of guilt. And caregivers thinking about wanting to kind of be done with it all and done with their caregiving roles, but this is someone who needs them and they have to kind of persist. So guilt is something that can really manifest distress for caregivers in the context of cancer. So recognizing that there's kind of this dual emotional burden, and how we address that if we're taking a dyadic intervention or if we're taking an intervention and adapting it dyadically, is really important, but it gives a lot of opportunity too. So if we're thinking about the caregiver's role a little bit more specifically, and this idea that caregivers are kind of witnessing a loved one go through cancer. And in some respects, there's a bit of a vicarious trauma that can happen through those medical experiences and how that informs their emotional health. And a lot of times, very common, this emotional avoidance that can happen and this protective buffering. So meaning, they put on a brave face and they don't want to be a burden for their loved one. And that can actually lead to a lot of dysfunctional coping because now caregivers are often avoiding conversations, avoiding maybe tough conversations about cancer and end of life, and really kind of isolating themselves from those around them. So being able to kind of rethink caregiver distress is really important. And if we talk about too, this idea of a caregiver role, it's really becomes a bit of an identity that people assume because it's so heavily integrated into their daily life. And it kind of shapes their relationships even outside of the person they're caring for. And so that also is a factor in terms of processing this caregiver role when we're working with them in psychosocial settings. So some of them may be spouses, like I mentioned, or adult children or friends or neighbors, but being able to take on and when we're talking with people in our life, the caregiver role is kind of the predominant topic and what they're thinking about. So that role shift can really cause a lot of identity issues and relational strain. And it can kind of exacerbate a lot of the distress we're talking about. So if we think about how we can maybe shift caregiver distress from this framework of burden, which it very much is for the caregiver, but as clinicians, how we think about the caregiver and the patient as a unit and a dyad so that we can better adapt these interventions so that the burden is the problem, but we're reframing it a bit in a way that the dyad has a lot of strength to help them foster connection and meaning and problem solving and coping as a way to really help them deal with the cancer. So this kind of shifts us to think about dyadic interventions and why it really matters, which I've kind of been breaking down and giving an argument for a bit with talking about caregiver distress. And it really starts to make no little sense to treat just patients alone considering how shared the distress is. And as much as the patient is our patient, you know, being able in some respect to understand the role of the caregiver and sometimes go beyond that to think about how we're adapting these interventions to better serve the dyad. So shifting from this person-centered and patient-centered focus to a more dyadic or family-centered psycho-oncology model, I think would really support a lot of these outcomes that we're working with. And being able to think about the multifaceted experiences of distress and how that informs what aspects of the intervention we adapt so that it makes sense clinically, and then how we can implement those. So I want to give a little bit of an overview of dyadic interventions in cancer, and then I'll shift to talk a little bit about the dyadic life review I've worked a lot on. I think situating what currently is being done in psychosocial oncology in dyads is helpful. But I will say too, there still remains a lot of inconsistency in terms of findings, and also a lot of kind of lack of cohesion when it comes to interventions being adapted and studied, and then other similar interventions might be adapted or studied, but then there's not necessarily a kind of standardization that happens. They struggle to get implemented into the clinics. But some really commonly used dyadic interventions in cancer are often skill-based trainings. And those can also include other components when it comes to relationship enhancement and communication. So really focusing on the skills when it comes to expressing emotion and understanding between the patient and the caregiver. Emotion-focused dyad and couple-based interventions. Those can help really target grief too, and anticipatory grief, and the changing roles that the patient or the caregiver is having as they go through the cancer experience. And then coping skills and problem solving, which are a bit more stress management focused and supporting the patient and the caregiver in day-to-day managing of appointments and treatment and decision-making. And the research has shown that patients and caregivers do seek practical tools. So there is a facet of managing distress where they are expressing that, you know, practical tools that they can use is really supportive. And then lifestyle interventions, which I touched on a bit when I talked about the physical toll of cancer on caregiving, and a lot of these multifaceted approaches that integrate exercise and nutrition into the intervention, relaxation and mindfulness-based therapies. But again, there's kind of many approaches at play, and I think the next step, which I'll touch on a little bit more, being how we sort of integrate and bring these together to feel like we have a little bit more of a standardized idea of what they look like in clinical practice. And then another interesting point when it comes to dyadic interventions is there is a clear, you know, acceptability in terms of patient and caregivers, and studies have shown that they do adhere to dyadic programs when they have a partner to do them with, which, you know, is found outside of cancer as well, compared to when just the patient alone engages in these interventions. So there's a bit of a shared accountability and mutual support. And I think this also kind of gives the importance and weight to these dyadic interventions and integrating the caregiver into each area of the patient's care. And dyadic coping skills training is a more specific adaptation that's been done in dyadic psychosocial interventions. This involves a lot of psychoeducation surrounding gathering accurate information about their cancer, understanding uncertainty about their diagnosis, enhancing their confidence in coping, and working with the patient and the caregiver to just understand what to expect, essentially, which can promote their coping. And this has been found to also support caregivers to feel actually more in control and promote their self-efficacy. Communication interventions are also a big area where there's a lot of dyadic adaptations, and it makes a bit of sense, right? If we're thinking about the dyad as a unit and how we foster that communication. One key piece having to do with reciprocal self-disclosure, which means the patient and the caregiver are openly expressing and sharing between each other their concerns, their experiences, and being able to state what their needs are with one another. And within communication interventions, oftentimes there's kind of a unique facet used where people will video record the dyads communicating, and that can kind of be a cool practice to show back to patient and caregivers to kind of break down their communication patterns, which is used a lot even outside of cancer. But I think pulling this into a cancer context with the dyad supports their communication styles to help them be able to talk more openly about cancer and talk more openly about their needs. And the outcomes show that patients and caregivers do talk a lot more about their diagnosis and being able to talk about, say, for example, advanced planning and end-of-life specific logistics, which oftentimes is a barrier for patients because they don't want to have those conversations. And caregivers often won't bring those up as well. So communication interventions can be really supportive to help dyads have these types of hard conversations. And in the mutual disclosure, further helps the patient and caregiver feel connected through the process. And then really quickly, I'll talk about there's cognitive behavioral stress management is a common dyadic intervention as well in cancer. And this has to do with really, thinking about those adaptive functioning cycles that I talked about earlier and breaking down a person's thought patterns and how they are responding to stress in those moments. And once we can bring those to their awareness, they're able to modify perhaps those reactions. And working with the dyad specifically, so they can really hold each other accountable and change essentially their behavioral responses to the stress can be really supportive. Oftentimes it incorporates mindfulness and relaxation, problem solving, and the cognitive restructuring. So now I'm going to shift to talk a bit about my own research, which has to do with life review therapy. And I'll talk a little bit about life review therapy traditionally and as an individual mental health intervention, and walk through kind of my process for adapting that as an example to think about how we might consider adapting interventions for dyads in cancer. And then in some ways too, being able to translate that over to a lot of the patients you all serve. So individual life review therapy has been around for a really long time, since I think like 1968. It's pretty well established in the realm of depression, end of life, older adults. So it's a structured therapeutic process where people recount important and meaningful memories in their life, and they'll be prompted to kind of think through specific examples in terms of those memories as a way to find meaning, resolve maybe conflicts that haven't been resolved, and enhance their well-being and sense of integrity at the end of their life, whether it be just kind of aging in general or through disease. And individual life review therapy has been used a lot in the cancer context, but in an individual way, especially in hospice as a way of legacy building and dignity therapy. So it sort of makes sense, right? We're processing our life and understanding meaningful parts and being able to take out of that what it means for us today. So to break it down a little bit more, the clinician kind of guides reflections through these structured prompts that help a person think about places or people or, main events in their life, starting from childhood, moving up through their life, and explore themes. So there are many themes depending on the person that could come through, but commonly sometimes ideas of resilience, a lot of relationship aspects, and a lot of meaning making, and being able to process the emotions that then come. So, if someone has experiences from earlier on and they may think they've resolved emotions, but it may come up in sessions, even though they haven't explicitly thought about the content of those memories in a while. So being able to reframe some of those experiences can be really supportive of a person's mental health. So life review therapy as an individual intervention has shown to support a lot of emotional health outcomes like distress, anxiety, depression in both older adults who are just living in the community, but also in the context of cancer and a few other chronic diseases. And as I mentioned before, it can really promote this idea of coherence and integrity, and help a person feel that sense of continuity in their life. So to give a breakdown of the structure for a dyadic life review, and I can speak a little bit too to life review as a therapy. In a lot of the work I've done with geriatric mental health, life review is a really kind of natural, organic process that occurs when you're working with older people. And I mean, personality matters too, but storytelling comes into play. And so it can really be a great kind of natural modality to foster later in life when a person's already kind of going to places, going to certain memories in their lifetime. So individual life review follows a similar structure, which I kept somewhat aligned to in my dyadic life review. So we go 8 weeks and starting with childhood, moving to the present. And I'll talk a bit more in depth about the specific adaptations, but within this structure too, one of the main differences that I'll touch on is session 4 and 8, where I kind of put a pause on the explicit memory and recall of parts of the patient and caregiver's life to have a chance to kind of reflect a little bit deeper on themes that were emerging during portions of the intervention, and then in the final session to have a bit more of a comprehensive overview to process what was coming up for the patient and the caregiver. I'll touch on these a little bit more. So with a dyadic life review, in adapting the intervention from individual format to be able to be delivered dyadically, I think thinking about a lot of what I just talked about when it comes to distress in patients and caregivers and cancer, and how we foster this idea of communal coping. So two individuals working together to cope with a shared experience. And kind of these 3 principles guided the adaptation process I took. The first being reciprocal self-disclosure, which I mentioned a little bit earlier, and it comes up a lot in communication interventions. It's really this idea that we're both equally engaging in a process to express ourselves and respond to one another and be vulnerable. And then what kind of goes hand in hand with that is this principle of responsiveness. If we're both sharing and disclosing, but neither are responding to one another, then it's not maybe going to be quite as impactful. And then the third is this idea, which emerged a bit also from my feasibility study, and I'll talk a little bit about that in a minute, is this idea of mutual empathy. So going through the cancer experience and patients and caregivers are, like I said earlier, in this survival mode, so reacting to things as they happen and not really having an opportunity to have space to reconnect and really hear out one another and recognize, we can kind of rationalize what the other's going through, but really empathize what, one or the other is feeling. So this intervention served as a chance to kind of promote that. So with these principles in mind, being able to promote communication skills to some extent, and really build a sense of closeness and connection between the patient and caregiver as mechanisms to hopefully reduce some of these emotional health outcomes that are common, distress, anxiety, and depression. And I will note too, there's different ways to look at outcomes in dyadic interventions. We could focus solely on the patient, which is often done. We could focus solely on the caregiver, or we could look at the actual dyadic interactions of these outcomes to understand maybe how, say, for example, a patient's communication is impacting the caregiver's depression. So there's a lot of kind of interesting ways you can look at dyadic interventions and be able to really break down a more complex picture, but more informative picture too about what's happening. So to specify the adaptation process, the biggest piece too is that it was delivered virtual. Back when I was adapting the intervention, that was sort of largely pushed because of COVID. It was when COVID was at the height of what was happening. But, you know, in the long run, it also, I think, makes a lot of sense just given the trends that are happening. And if we think about cancer, and in the context of this life review study, older adults and aging, virtual formats are just really supportive, you know, with transportation issues, or they're already managing so many appointments and they may even have physical mobility issues. And another feature that's not on here, but that kind of came through that's neat is it does support this idea of dyads because sometimes the caregiver isn't physically with the patient at a given time point in the day. So it does give a little bit of an opportunity to still meet those needs, you know, and it not be another barrier where they can't find like a mutual physical time to go to an appointment together. So it did serve that as well. And then I mentioned briefly earlier this adaptation with the session 4 and 8 for the dyadic processing. And that was different than the individual life review process. And it was a chance to facilitate a deeper reflection between the dyads, really synthesize the main ideas and have them have an opportunity to have dialogue and share their perceptions of one another. And I will share a few examples in a little bit. It's kind of neat to see how they are able to talk with one another and be kind of put on the spot to share perceptions of one another. And then more specifically within each session, the prompts were taken from the structured handbook of individual life review, but where the adaptation was included was being able to think about how to fully integrate the caregiver into the process. So even with some of the dyadic interventions I shared earlier, you know, we call it dyadic, but the caregiver sometimes is still on the periphery of that process. So the questions, even in those interventions, may still fully address the patient and just have the caregiver present to facilitate the process. And it was really important to me that this intervention, like, really equally see the dyad as a true dyad in a unit and how the caregiver is a full part of the process. So the patient and the caregiver were each prompted the same prompts. So the patient would share their memory from that specific prompt, and then the caregiver would have a chance to share from their own life experience as well. And then also more specifically, this idea of responsiveness, to take that into consideration, being able to explicitly guide them to respond to the other's memory or reflection that came up at that time. And take turns doing that. And it didn't always go that far, but at least they were given the space and the opportunity to be responsive to the other person's expression in that moment. So to give examples of these adaptations a little bit more concretely, with this idea of reciprocal self-disclosure. So on the left, the example is from a content session. So I think session 1 with childhood. So this idea where we're prompting the patient to share who was most influential during their childhood. And they go, you know, are able to share and reflect. And the therapist in the trial was given kind of freedom with their clinical judgment to prompt deeper if they needed to, or kind of take what they were giving and move on to the next prompt. So sometimes, you know, the first prompt could take 20 minutes and other times it could take 5. So it was really subjective to the dyad. But I think in that respect, it kind of gives a chance for each dyad to tailor the intervention to each dyad. So then the caregiver is given an opportunity to share a response to the patient specific to what they just shared. And then switching over to guide the caregiver to share who may be their most influential person at that time. And again, the therapist may prompt for more emotional processing or, you know, just therapeutic questioning to understand a little bit more why that was so meaningful to them. But then the patient's also given an opportunity to respond to the caregiver's memory. And then for session 4 and 8, to give some examples that also pull from those principles of reciprocal self-disclosure and responsiveness, being able for the patient and caregiver to share what stood out, not just for themselves, but from what the caregiver shared during the sessions. So session 4 would cover those first 3 sessions as an overview. And then vice versa, the caregiver could share specifically what about the patient really stood out for them. And then the interventionist was able to kind of guide for deeper reflection over time. And then session 8 was kind of mirroring session 4 a bit. It did go a step further with this final adaptation, which had explicitly prompting them to share what was one thing they'd want to say to the other person, which was a really kind of neat point of the sessions after working with these dyads for 8 weeks to kind of think about what route they took in terms of what they wanted to say in the context, especially of advanced cancer and aging. And again, just to kind of reiterate, giving the opportunity for one or the other to respond. As an overview of the study, so this was a single arm feasibility study to really adapt this intervention and just see if it worked and see if patients and caregivers liked it. We enrolled 19 and 12 completed the entire intervention. The patients were a bit older than the caregivers, mostly white, and the caregivers were more female, which is sort of in line with caregiving statistics. For cancer staging, we did include only stage 3 and 4. So all these patients were advanced and curable diagnoses, but they were cancers of any type. So there's still some variability in terms of their experiences with the cancer. So for example, a stage 3 prostate cancer looks very different than a stage 4 pancreatic cancer. So, but as a feasibility study, it made sense to kind of keep it open to gather and characterize what their experiences were with the intervention at different kind of time points in their diagnosis. And then we did also have differences in dyadic relationships. So most of them were significant others, but we had some parent and adult child, and I had one dyad that was siblings. So again, this idea to really get feedback from different forms of relationships and understand maybe how they were experiencing this intervention, so that with the next step that we take with the study, maybe tailor the intervention even further for one specific dyad type. And to give a little snapshot on some measures that we looked at, is a small sample, but we were able to look at some response means. And I will point out too that we didn't screen for distress, so we kept that open too. So patients or caregivers weren't necessarily distressed. There was a pretty good range between the dyads though in terms of distress scores, but we did see responses. 58 of the patients improved in distress and 50% of the caregivers. And then in relationship closeness, we saw that the patients felt closer, not as many caregivers there, but within dyadic coping, which measures for how we perceive that communal coping aspect within the dyad, caregivers did show a sense of improved coping. So these kind of give us an idea of maybe some experiences and therefore measures that we can think about that this intervention is targeting and be able to adapt it even further for the future. And I did want to share too some of the quotes that patients and caregivers in the interviews provided. Pretty overwhelmingly, it was very positive. We did ask about logistics and the structure in the 8 weeks, and everybody was okay with the format. So none of those quotes are up there, but I did share some of just the general experiences that people had. And then one that stood out to me a bit too, just in the realm of, mental health and how we all as mental health providers think about our work. One of the caregivers in particular highlighted that down in the bottom left, it just seems like this is something, when we think of healthcare, the emotional is as important as the physical. So it gives a little bit of weight to think about too, how we are integrating this idea of psychosocial oncology into cancer care, and how these interventions impact patients and caregivers. So to kind of summarize the clinical implications of this dyadic life review, and I think in a lot of ways just have it serve as an example of how we might think about how we adapt psychosocial interventions we already have to be delivered in a dyadic format. This was able to enhance emotional processing by supporting both the caregiver and the patient, specific to the cancer-related distress, facilitate meaning making, and really, in a lot of ways, what came through in the sessions is reconciling past conflicts, strengthening that relationship quality and that closeness that I touched on. So kind of, again, that heart of the intervention being that mutual empathy that you're fostering and helping one or the other provide validation to their partners, improving their communication skills, and then therefore reducing a lot of the relational strain they might feel. I did have a few dyads who were in high conflict coming into the study, and I wasn't quite sure if it would be very supportive as a modality in that context, but those are the dyads we're looking at, the transcripts and the interviews. This idea of mutual empathy really emerged because they were pretty explicit about that towards the end too. I think being able to, even though they had heard a lot of these memories before, they knew the content of a person's life. They hadn't really taken the opportunity to kind of rehear it. And in the context of the stress they were experiencing with the cancer, I think it was able to kind of break down that stress a little bit more and really foster that empathy, and help one or the other understand during the stress why this person responds the way they do. And so that kind of came through a lot too. And then specific to the caregivers, really, again, making sure that they were equally integrated into the intervention. And I think that was really key and a big takeaway too for why this all matters to me, and hopefully conveying that message of thinking about the caregiver not just being this passive participant, but really an active part of the whole picture. And then more broadly, how we integrate all of this into psycho-oncology care, and thinking about our existing mental health and supportive care frameworks we use and models within our psycho-oncology clinic or other clinics, and how we might be able to build infrastructures that enhance that dyadic centered approach. And so along those lines too is this idea of scalability. So if we're thinking about virtual delivery and expanding the accessibility, but also other barriers that might exist, and working with staff within clinics and what it looks like to scale interventions to, really have a true integrative approach to psycho-oncology. So I kind of touched on some of those just from the implications of this study, but just to kind of emphasize a little bit more deeply how we might implement these interventions into psycho-oncology clinics. And I think it, again, can be considered too in other clinics that serve other populations, and how we're able to break down and target distress and problems that are happening, and use those to guide our adaptations of interventions, so that we can serve dyads versus individuals. And there is a lack of training in dyadic approaches across a lot of clinics. Coordinating, multiple appointments can be a bit of a barrier, especially with two people. So sometimes that also can hinder the forward movement of these interventions. Like most interventions, just the readiness. But I think if we think about dyadic interventions versus individual interventions, there's a different level of readiness I think you have to sit with someone in your life and go through a process like that with them. And then considering different cultures and ways about caregiving and how different families might perceive their role as caregivers, and further how different families might even receive disclosing things to family members in mental health settings. And then I wanted to make a point too about this idea of shifting dyads. There are many, many cases where it's not always just one caregiver, but there might be like 2 or 3 people who are primary caregivers. And so when we think about these dyadic interventions, we're serving maybe one caregiver, but it can get a little complex. And I even had a few when we were recruiting where there were adult children caregivers, and they all wanted to participate and they couldn't decide who would participate. So it just kind of pointed to this need I hadn't thought about when it came to thinking about shifting dyads, and, maybe even beyond all of this, like family approaches that for those who work with families might consider. And so to kind of summarize, all of these pieces. Just emphasizing the psycho-oncology care must evolve to be more inclusive of patient and caregiver relationships. I think that dyadic interventions really serve as this modality to be really promising, to address a unit who is operating together, separate and together, but it kind of is an efficient way to think about how we're supporting this unit during a really difficult time and scaling those interventions. Being able to incorporate other disciplines, especially in psycho-oncology, maybe how we're scaling those interventions to train staff who interface with patients and caregivers, and even scaling interventions sometimes to be very small, where it is simply the dialogue we're having or the information we're gathering from a caregiver within that given moment. And then us as clinicians, how we are incorporating, even thinking about dyads into our sessions, even if it's with an individual, and being able to understand maybe more in depth, especially in the context of cancer or other diseases that our patients might be living with. Who are they relying on? So going back to that quote too, who do they need and who do they rely on? And that's a big part of the picture. Sometimes I think we miss and we don't think to capture early on. And using all of this to develop better training opportunities and foster, adaptations that lead to pilot testing, like the dyadic life review intervention, and developing more clinical processes, therefore, that have infrastructure to support the dyadic interventions. Thank you.
Thank you. That was great. Okay, well, we have time for questions.
Thank you so much for giving us this talk, this presentation. I think the question of what happens to the caregivers after I discharge a patient home is one that I often think of, but then I find myself trying not to think about too much because I feel like there's nothing I can do about it.
Right.
And part of me thinks, if the caregiver has trouble, they'll see their PCP or find their therapist or whatever. And also, I've lived through enough of scenarios like this to see caregivers who don't do that because they're too busy taking care of whoever
Absolutely.
the person is. So yeah, just thank you for all this research and helping to bring some light to that. I guess I'm also wondering, so in terms of the plans for your research, are you mostly thinking of staying in the kind of psycho-oncology area, or are you thinking of investigating other types of illness diet?
That's a great question. So I right now I'm a KL2 scholar. So I have this study now as a pilot RCT. So looking at the dyadic life review after the adaptations I described, compared to usual care in cancer, which is, just to give a context, usual care is we screen for distress every 3 months in the patients, not the caregivers, and they get a referral to social work. And then beyond that referral, they may come to psycho-oncology, but they also may just be referred to the community, or they may just get a phone call. So I'm comparing to that to see as an option in advanced cancer. But I also, going forward and applying for a career development grant, am thinking about how to further adapt and integrate Alzheimer's disease into this intervention. And life review has been used in Alzheimer's. It makes sense, right? And how it could work for that population. But in cancer and Alzheimer's in older adults, there's a really high comorbidity. So even to consider this intervention in people with cognitive impairment, I think makes a lot of sense. So that's another area that I'm kind of thinking about, and how this intervention could serve that population.
Thank you.
Okay, let's do a question then from Zoom and then you here. And this question is, what information do you gather about the quality of the dyadic relationship prior to intervention to help inform if the dyadic life review might be effective and useful?
Yeah, so we used relationship closeness measure, the unidimensional relationship closeness scale, which is a common relationship measure. We also used the dyadic adjustment scale, which looks at coping. again, dyadic coping, a little different than just like individual coping. So it really targets how that person perceives coping together. And then we also looked at perceived stress from either patient or caregiver, both pre and post. So those are kind of the main relationship focused measures that we used.
Okay.
Thank you. So I really enjoyed this talk. It's just wonderful to basically kind of, see all this come to fruition and think about this problem like from so many different angles. And I have many thoughts that came to my mind as you were going through it, but and one of them to kind of run on to what was said before is it's kind of this very invisible population, if they're being discharged or you're just seeing a patient in clinic. And I'm thinking from the oncology side, how many times you're just seeing a patient, you sort of know what the dynamics are, but you're not really that, you don't quite get it yet. And in like how much of an opportunity there really is to start to define this in a way. Like I could see this being something where, let's say on the oncology side, oncologists want to help and they want to understand what's going on with their patients. And this is kind of, we've always used the stress, right? This sort of the way to get to our care. But, this is like another avenue. And similarly thinking about, for whom or for which dyads this is the best. And I started to think about like, in psychoanalytic formulation, how would you, how do you sort of describe all of these different dyads? Because of course there's patterns, and the like. And that could also be sort of like another sort of direction to go in. Another possibility, as you know, in our service, we want to do this collaborative care model. And so, that could be another area where you find a patient who's distressed or dealing with something. And this is actually what the primary issue truly is. And so it's, the other part of it that I think is just so rich is that, it's always impressed upon me how, especially with cancer, we sort of wrangle patients into like, okay, now you are a patient, you are gonna, and we don't do a good job of this acculturation into being a patient and what that means. And part of it is the caregiver and the unit and the dyad and the family. And we really have no idea what goes on sort of behind the scenes. Because, as you know, it's like caregivers are like the backbone of our healthcare system, and yet we know nothing, right? And so it's but I also think about it from that perspective because you have dyads and patients that really are embittered by having to do this, or and so it's again, like for whom is this intervention the best? So those are the questions I sort of would have around it. So kind of what are the ethical conundrum too?
Yeah, and I think this idea of characterizing dyads is a stepping stone, and thinking about modalities like review that provide this opportunity to actually get the story a little bit, and then maybe be a launching point to more specific. So there's so many kind of ways to scale and think about that. But characterizing the dyads is a step that maybe we've missed.
Okay, well, we have another question from Zoom.
Have you ever studied dyads where patient and caregiver were not both geriatric? For example, someone in young adulthood taking care of a boomer parent or boomer parent caring for a young adult patient. Has this been researched?
Yeah, in my research specifically, I specialize in geriatric mental health. So the caregivers even are 50 or older, which is, not necessarily geriatric, but, in that later end of life. But clinically, I have served, a lot of variability in dyads. And I think that's where, too, the point I made earlier about the complexities of the strain, especially young adults, I think, grandchildren, and they're not quite as common statistically as caregivers, but, more so maybe middle-aged, right? Like 40-year decade, and these people who are caring for their parent, caring for their children, juggling actual life at a fast pace. So I think in those cases, the distress can be really intense. I did have a dyad in this study where the caregiver was 50. So met that cutoff, right on the dot, but, they still kind of fall into that midlife range where they had teenagers in their house. And actually her husband also had a progressive disease. So it just, again, was an example too of just how complex I think caregiving can be at these stages of life for people.
Kim?
Great job, Lee. I was wondering if you could speak just briefly to how you think if this intervention might improve end of life outcomes for patients and how they manage cancer.
Yeah, that's a great one too. I think in working clinically, in my experiences in the community, primarily were in kind of anticipatory grief and this idea of end of life. And, I think about this intervention too, because it's so inherently, there is grief so inherently in the process and within the sessions, grief coming up. Although I will say, and I didn't mention this earlier, but something interesting from the intervention is I think patients were surprised it wasn't so cancer heavy, but then at the end, they actually liked that because so much of the interventions they're going through are all about their cancer. And it was an opportunity to just be a person again and be a person with their person again. And the cancer did come up though, once we got to the present day life, because it's significant, significantly impacting them. So towards the end, that anticipatory grief started to really come out and a little hinting at end of life planning and, being able to actually say out loud, what was happening, which for some of them came natural and they were kind of had already coped and processed and accepted. And for others still could not use the explicit language. So I think it can serve in a lot of ways, even to think about how we scale and adjust it, maybe more specifically for palliative care or hospice care, to target outcomes like grief or bereavement specific to the caregiver, or even thinking beyond death, following up with the caregivers later on and seeing maybe how that served them, to grieve and to prep for grieving. So.
All right, well, I had a question and maybe you can email me the answer. I'm running out of time. But I noticed the groups you're talking about, advanced cancer or geriatric, these are all people with end of life type condition. But I was wondering if this approach has been used in other cases, let's say where you had a spouse that was paralyzed or went blind or had MS or something like this. So it's not an end of life situation, but clearly there's a dynamic changing in the relationship.
Yeah, I think that's a great point. I haven't looked at it in that way, but I think to serve as even a modality, if we think about life review as a way to examine our life as it was, and now maybe our life as it's becoming, and being able to do that though with the person who's caring for you, even in the context of a trauma, like some sort of major trauma or vision loss or, major life change. I do see where it could be adapted in that context to serve that as well. I think especially along the lines of coping, if really that mechanism at play is, that connectedness, and we're trying to promote the coping with the dyad. There are ways to kind of tailor, and maybe more specifically, even thinking about the trauma itself and how that's processed as a dyad, the trauma being also the news that you have some sort of condition, so I can see a lot of ways it serves as a vehicle, really, right, to support people in these different disease groups or contexts.
All right, well, this has really been fascinating, and thank you so much for a great presentation.
Thank you, everybody.
And thank you all for coming.
Thanks, Sean.
You got it.